This is the fifth video in this series on hemostasis, and today I'll be discussing antiplatelet medications. Because there's a lot to cover in this topic, I'll be dividing it into two parts. This one will be an introduction, and we'll discuss aspirin, which is historically one of the most important medications of all time. Part 2 will cover every other antiplatelet drug. The learning objectives are very straightforward. To describe the structure, mechanism, pharmacology, indications, and side effects of the antiplatelet drugs, including aspirin, the P2Y12 inhibitors such as clopidogrel, 2B3A inhibitors, dipyridamole, and cilostazol. Here's a diagram we first saw in the second video on the normal physiology of platelets. It shows how vascular injury leads to exposed collagen, triggering platelet adhesion and activation, which then leads to a process of amplification of the activation through platelet release of fibrinogen, von Willebrand factor, ADP, and thromboxane A2, along with other factors such as thrombin. Helping to mediate the effects of each of these compounds are specific receptors such as the P2Y12 receptor for ADP and the 2B3A receptor, which binds to fibrinogen and von Willebrand factor to support platelet aggregation and the eventual formation of a platelet plug. Different medications interfere with this complex process at different points. For example, the most commonly prescribed antiplatelet drug, aspirin, inhibits the production of thromboxane A2. The P2Y12 inhibitors clopidogrel, prasugrel, ticlopidine, and ticagrelor all predictably block the P2Y12 receptor. The GP2B3A inhibitors over here include three drugs: ebtifibitide, tirofiban, and apixaban. The drugs dipyridamole and cilostazol are both phosphodiesterase inhibitors, which have somewhat more complex and obscure mechanisms, which partially involve modulating levels of cAMP and cGMP. Finally, although this new class of medication is not yet widely used, and thus I won't be covering it in this video, vorapaxar is an antagonist of the PAR1 receptor. The first drug to discuss is aspirin. Aspirin, also known as acetylsalicylic acid, which is occasionally abbreviated ASA, is one of the world's first effective medications and remains one of its most common. Because of its widespread use and diverse indications, I'll spend a bit more time on this drug compared to the others. The history of aspirin begins about 3,000 years ago in ancient Egypt, when preparations of willow bark were used to relieve pain and fever. The first remotely formal description of the use of aspirin was 400 years before the Common Era, when Hippocrates described the use of various parts of the willow tree for treating pain. In the early 19th century, within the span of a few years, numerous organic chemists isolated compounds called salicin and salicylic acid from the willow, and the use of these to treat pain and fever grew modestly. However, their use was limited by significant side effects and an awful taste. Then, at the turn of the 20th century, several chemists synthesized a similar compound called acetylsalicylic acid, which had fewer side effects. Popularity rose significantly during the Spanish flu pandemic of 1918, which coincided with the expiration of Bayer's original patent. At the time, aspirin was essentially the only medication known to reliably reduce fever. Now, the mechanism of aspirin wasn't actually discovered until the 1950s, before which it was believed that aspirin's pain-relieving effects occurred directly within the central nervous system. It was work on a group of biological compounds called eicosanoids that led to aspirin's discovery. In the second video in this series, we looked at this diagram, which outlines the synthesis and regulation of prostaglandins and thromboxane A2. To remind you, thromboxane A2, which helps to activate platelets, is produced from arachidonic acid by three steps. The first two are catalyzed by different sites on the same enzyme, which can be either cyclooxygenase 1 or cyclooxygenase 2, both of which are occasionally referred to instead by the name PGH2 synthase 1 and 2, or the name prostaglandin endoperoxide synthase 1 and 2. Although less common, use of these names highlight the fact that the cyclooxygenase activity is only responsible for the first step, the conversion of arachidonic acid into PGG2, while the enzyme's peroxidase activity is responsible for conversion of PGG2 into PGH2. The general mechanism of aspirin is that it irreversibly acetylates a serine residue in the cyclooxygenase active site, thus ultimately inhibiting production of PGH2. Because the activity of aspirin on the serine residue in question varies between the COX-1 and COX-2 isoenzymes, the consequences of this inhibition depend upon the aspirin dose. At low doses of 75 to 100 mg per day, aspirin acts primarily on cyclooxygenase 1, which inhibits platelet generation of thromboxane A2. The consequence is a modest, generalized antithrombotic effect. At higher doses, such as above 325 mg, aspirin acts on both cyclooxygenase 1 and 2, leading to an anti-inflammatory effect. This is the reason for the significant dose dependence of aspirin's clinical effects. So what are aspirin's indications? There are many. I'll talk primarily about 6. The clearest indication for aspirin is acute coronary syndrome. Numerous trials show that patients given aspirin immediately after presenting with either an ST elevation MI, non-ST elevation MI, or unstable angina have improvement in various markers of cardiovascular morbidity and mortality. The recommended dose in this situation is 162 to 325 mg daily, starting immediately. The first dose should be crushed or chewed in order to maximize speed of absorption. What is commonly done in the US is to give 4 chewable 81 mg tablets, since they are believed to be faster absorbed than a single 325 mg tablet. The next indication is acute ischemic stroke. A meta-analysis of 12 randomized trials found that aspirin of dosages 160 to 300 mg daily, started within 48 hours of symptom onset, resulted in an absolute risk reduction of death and dependency, with a near negligible increased risk of intracranial hemorrhage. As that perhaps implied, in practice, initiation of aspirin following stroke is generally not felt to be as time critical as it is in acute coronary syndrome, though I'm honestly not sure why that's the case because they would seem to be somewhat analogous situations. Next is the secondary prevention of cardiovascular disease, which is more or less an extension of the first 2 indications. A meta-analysis looking at a variety of endpoints in patients with known cardiovascular disease already, who were randomized to either aspirin or placebo, found that aspirin reduced rates of MI, rates of stroke, and all-cause mortality. Comparison of appropriate doses indicate that low doses of 75 or 81 mg daily is likely as effective as higher ones and associated with fewer side effects. An obvious question that might be raised by this is if acute MIs and acute strokes are treated with 162 to 325 mg daily, but for secondary prevention, patients can be treated with just 75 or 81 mg daily, at what point after a cardiovascular event should the dose be lowered? There seems to be some variability in practice. I personally lowered it down to 81 mg when the patient is discharged from the hospital, but there are others who continue a higher dose as an outpatient for some arbitrary length of time. Aspirin is also used for the primary prevention of cardiovascular disease, particularly in older individuals with cardiovascular risk factors. A huge meta-analysis looked at this question in 2009 and found that aspirin reduced the composite endpoint of any serious vascular event, but the effect was largely due to preventing non-fatal MIs. There was no statistically significant difference in mortality. And even data on primary prevention of cardiovascular disease in diabetics is conflicting. Most guidelines currently suggest calculating the 10-year risk of cardiovascular disease based on statistical models which can be easily looked up on the internet, and balancing it against the risk of side effects. On the whole, I'd say that the use of aspirin for primary prevention of cardiovascular disease is not nearly as supported as it was a decade ago. For example, when I was in residency, it was a given that a 60-year-old man with hypertension or diabetes, but no known cardiovascular disease, should be on a daily aspirin. But now, in 2015, that's actually quite debatable. How about using aspirin to prevent stroke in patients with atrial fibrillation? It's occasionally used in place of anticoagulation in patients with non-valvular AFib when either embolic risk is believed to be small, that is, the patient has a CHADS VASC score of either 0 or 1, the patient has a contraindication to anticoagulation, or the patient declines anticoagulant therapy. If you're not familiar with the CHADS VASC score, it's a simple system for predicting the probability of developing an arterial clot in patients with AFib. I'll be discussing it more in the next video on anticoagulation. A meta-analysis has found that compared to placebo, aspirin conveys a 0.8% absolute risk reduction in the primary prevention of strokes in patients with non-valvular AFib, and a 2.5% absolute risk reduction in the secondary prevention of stroke. Although those numbers may sound pretty small, considering that aspirin is very cheap, well tolerated at low doses, and the consequences of a stroke potentially so profound that both the risk-benefit and cost-benefit ratios are still quite favorable. However, because most patients with AFib have CHADS VASC scores above 1 and have no strong contraindications to anticoagulation, anticoagulation is still recommended over aspirin for most patients. The final aspirin indication I'll discuss is the possible prevention of cancer. There is some emerging data that suggests long-term use may reduce the risk of developing numerous types of cancer and may lower the risk of cancer-related mortality. The conditions which have been most studied are colonic adenomas and colorectal cancer. Although most studies, including prospective randomized controlled trials, have found some sort of benefit, significant heterogeneity in study design has resulted in no clear consensus as to which specific patients are likely to benefit and what the optimal aspirin dose should be. Due to these uncertainties and the small but non-negligible risk of GI hemorrhage from aspirin, both the American Cancer Society and the United States Preventative Services Task Force currently recommend against the routine use of aspirin for the purposes of preventing colorectal cancer. So that was a lot of information regarding the indications for aspirin. Let me summarize it in a quick table. Strong indications include acute coronary syndrome, acute stroke, the secondary prevention of cardiovascular disease, and non-valvular atrial fibrillation, but only in those patients whose CHADS VASC score is 0 or 1, or those in whom anticoagulation is contraindicated. Modest indications for aspirin use include primary prevention of cardiovascular disease, but only in those patients with higher than typical 10-year risk of developing such. And aspirin is not generally indicated for cancer prevention. Now, some of you might wonder why I have not mentioned the two indications for which aspirin originally became popular 100 years ago. That is, what about taking aspirin for pain relief or to reduce fever? Well, in the 21st century, aspirin is not best used for either of these indications. While it can be effective, the non-steroidal anti-inflammatory agents such as ibuprofen and naproxen are as effective and have fewer side effects than aspirin when aspirin is used at the high doses necessary for its anti-inflammatory and antipyretic effects to be evident. So what are the side effects of aspirin? At normal therapeutic doses, including the relatively high doses for pain relief, the primary adverse effect is upper GI bleeding. There are two mechanisms of this. The major mechanism is systemic COX inhibition, which is because the healthy gastric and duodenal mucosa constitutively use COX-1 to produce its mucosal protective prostaglandins. The minor mechanism of aspirin-induced GI bleeding is local direct toxicity on the GI mucosa. Because the major mechanism is a systemic one, it should come as little surprise that so-called enteric-coated or buffered aspirin has no effect on clinically relevant GI bleeding, though there is anecdotal evidence these formulations may be associated with a decrease in subjective GI upset. Risk factors for aspirin-induced GI bleeding include a history of peptic ulcer disease or gastritis, advanced age, concurrent use of steroids such as prednisone, NSAIDs, other antiplatelet drugs or anticoagulants, and concurrent use of alcohol. Aspirin is also associated with increased risk of intracranial hemorrhage, but the absolute risk is still small enough that this is typically a relatively minor concern. In addition to the bleeding side effects, acute aspirin overdose is associated with a relatively distinct pattern of toxicity. Symptoms and signs of a mild overdose include nausea, vomiting, diarrhea, tinnitus, and vertigo. Symptoms and signs of a severe overdose include fever, lactic acidosis, a respiratory alkalosis, non-cardiogenic pulmonary edema, confusion, and coma. The danger from aspirin overdose is primarily related to the amount ingested relative to body weight, assuming it's all ingested at approximately the same time. The treatment for aspirin overdose is largely supportive care, but also includes activated charcoal if the ingestion was within the last 2 hours, alkalinization of the urine with sodium bicarbonate infusion to promote excretion of salicylic acid, and supplemental glucose to prevent cerebral hypoglycemia, which can be present even in the setting of a normal serum glucose. So that was a lot about aspirin, and it brings us to the end of part 1. This is part 2 of antiplatelet medications, and I'll be starting off with the P2Y12 inhibitors. The P2Y12 inhibitors predictably inhibit the P2Y12 ADP receptor on the platelet surface. Although it seems that most physicians are not familiar with the formal name of this particular medication class, they may instead know them as the thienopyridines, since most fall into that particular chemical classification. These include clopidogrel, commonly known by the brand name of Plavix, prasugrel, which is occasionally known by its brand name of Effient, and the rarely used ticlopidine. Thienopyridines are all based upon this structure. Other common features of the thienopyridines include oral formulations only. They are all prodrugs, which require in vivo biotransformation into the active drug, and they all irreversibly inhibit platelet aggregation. In addition, there is one non-thienopyridine P2Y12 inhibitor, which is called ticagrelor. Ticagrelor is a nucleoside analog with a chemical structure similar to that of adenosine. Compared to thienopyridines, ticagrelor binds reversibly to the P2Y12 receptor, has a quicker onset of action, and a shorter duration of action. Thus, it needs to be given twice daily, which is its major disadvantage compared to the other P2Y12 inhibitors. What are the common indications for the P2Y12 inhibitors? Acute coronary syndrome, in addition to aspirin, anticoagulation, and plus-minus a GP2B3A inhibitor. The specific choice of drug depends on the situation. If receiving PCI, that is, the patient is getting angioplasty and a stent, the general preference is for either prasugrel or ticagrelor. If the patient is receiving fibrinolytics, the preference is for clopidogrel, and if receiving neither PCI nor fibrinolytics, the preference is also for clopidogrel. Clopidogrel is also used for secondary prevention of non-cardioembolic stroke or TIA, but only by itself and not in combination with aspirin. Combining clopidogrel and aspirin in this situation results in no improvement in stroke reduction, but does result in an increase in clinically relevant bleeding. Finally, for secondary prevention of cardioembolic stroke, or TIA, clopidogrel plus aspirin is used in patients who are not candidates for oral anticoagulation for reasons other than bleeding risk, since the risk of bleeding from clopidogrel plus aspirin is similar to that from anticoagulation. Keep in mind that these indications are very fluid based on evolving data and could become obsolete with the next big clinical trial. There are also local institutional preferences which may differ slightly, and the cost of some of these drugs may be an additional consideration in some areas. A common question which comes up regarding use of these drugs is how long should they be used after PCI? Patients who have received a bare metal stent, absolutely must be treated for at least 1 month to prevent in-stent thrombosis. Patients who have received a drug-eluting stent absolutely must be treated for at least 3 months. In the absence of a contraindication such as bleeding or non-elective surgery, evidence supports continuing treatment for 12 months, irrespective of choice of stent. And some cardiologists prefer treating beyond 12 months, but there is currently insufficient evidence to broadly recommend this. Some additional notes about the P2Y12 inhibitors. Clopidogrel has a longer onset of action compared to prasugrel and ticagrelor, and may be less effective at preventing cardiovascular morbidity, but is associated with less bleeding. Prasugrel is contraindicated in patients who are 75 years or older, and in those with a history of stroke or TIA, as a consequence of observed higher rates of intracranial bleeding in these patients. It also needs to be dose reduced or avoided altogether in patients of low body weight. The P2Y12 inhibitors increase the risk of major bleeding in patients undergoing urgent coronary artery bypass surgery. The common approach to this issue is to withhold the drug for 5 to 7 days prior to surgery. However, there is some variability in this practice, and there is insufficient evidence to make any specific recommendation. Finally, I mentioned earlier that cyclopidine is rarely used. That's because it's associated with neutropenia and a potentially fatal hematologic condition called thrombotic thrombocytopenic purpura, which I will discuss later in this series. The last aspect of P2Y12 inhibitors to discuss is that of clopidogrel resistance, also known as clopidogrel non-responsiveness or high on treatment platelet reactivity. This refers to a lack of clinically meaningful inhibition of platelet activity after taking clopidogrel. Proposed etiologies of this include variations in the metabolism of the drug into its active form, as well as drug-drug interactions. Several years ago, there was a lot of concern regarding some modest quality evidence that proton pump inhibitors may interfere with the action of clopidogrel. But based on the current body of evidence, this seems to most likely not be true. However, it remains controversial, and some physicians may still show preference away from concurrently prescribing clopidogrel and PPIs. The generally accepted clinical presentation of clopidogrel resistance is simple: recurrent thrombotic cardiovascular events despite treatment. To me, this seems to be overly inclusive, since a recurrent event is not necessarily indicative of there being no meaningful platelet inhibition. After all, patients on aspirin still get recurrent events all the time. Nevertheless, that's the definition some of the literature uses. Despite the fact that this sounds like it should be a big deal, routine screening of patients for clopidogrel resistance is surprisingly not currently recommended, since it hasn't yet been shown to lead to any benefit. The next class of medications is the GP2B3A inhibitors. Recall that the 2B3A receptor serves as part of a bridge, along with fibrinogen and von Willebrand factor, to attach activated platelets to one another. Inhibitors essentially prevent these receptors from doing that job. As mentioned at the beginning of the video, there are 3 members in this class. Eptifibatide and tirofiban are relatively small, non-antibody inhibitors, while apixaban is the Fab fragment of a chimeric human murine monoclonal antibody. All 3 of these drugs are given via continuous IV infusion. Initially, when they were first developed, the 2B3A inhibitors had a larger role in the management of ACS, but with the subsequent development of P2Y12 inhibitors, their role has become somewhat reduced. In addition, the current body of literature on them is quite dense and looks at very specific combinations of drugs in specific situations. Generally speaking, the current indications for 2B3A inhibitors include use at the time of PCI in an NSTEMI if either the chosen concurrent anticoagulant is unfractionated heparin and the patient receives pretreatment with clopidogrel, or if the patient does not receive adequate pretreatment with any P2Y12 inhibitor, irrespective of choice of anticoagulant. In addition, they can also be used in unstable angina or NSTEMI prior to PCI if there is evidence of ongoing ischemia, irrespective of the choice of anticoagulation and P2Y12 inhibitor. In practice, I currently find their use prior to PCI to be quite uncommon. The next drug to discuss is dipyridamole. It has multiple mechanisms of action. First, as a phosphodiesterase inhibitor, it inhibits PDE5 and to a lesser extent PDE3. This raises platelet CAMP and cGMP with a secondary effect of decreasing platelet responsiveness to ADP. It also inhibits the reuptake of adenosine by red blood cells, which leads to higher concentrations of plasma adenosine and subsequent platelet inhibition. Dipyridamole also acts as an antioxidant, which scavenges the free radicals which normally inactivate cyclooxygenase, thereby enhancing PGI2 synthesis by the endothelium. And finally, it acts as a coronary vasodilator, an effect not directly related to hemostasis, but is related to its use in myocardial nuclear imaging, where it is marketed under the trade name Persantine, as in a Persantine stress test. Despite all of those mechanisms, for the purposes of preventing hemostasis, dipyridamole is not very frequently used. In fact, I've never personally seen it used outside of a combination with aspirin in a medication marketed under the trade name Agrinox. And Agrinox is only used for the secondary prevention of non-cardioembolic stroke, or TIA. Because it has an equivalent effectiveness as clopidogrel for this indication, and because Agrinox is a twice-daily medication with a relatively common side effect of headache, most physicians prefer prescribing clopidogrel in this situation. The final medication to discuss is cilostazol. This acts as a selective PDE3 inhibitor, which increases CAMP, leading to platelet inhibition and vasodilation. Its indication is primarily for symptomatic improvement in peripheral artery disease, that is, it reduces claudication. There is also limited data supporting possible use for secondary stroke prevention in Asian populations, though at least in the US, I've never seen it used for this reason. Cilostazol may take 4 weeks for symptomatic benefit in patients with claudication, so patients should not write it off if they don't see any improvement after just a few days. And finally, it is considered to be contraindicated in congestive heart failure. So those are the antiplatelet medications in current use. Here's a table summarizing the medications, their mechanisms, and their common indications. I'm not going to go through the table line by line, as you can obviously pause the video if you'd like to review it on your own. That concludes this 2-part video on antiplatelet medications. Sorry it was on the longer side, but it's kind of a big topic, similar to the next one on anticoagulation.